Okay, welcome back, everybody. We're going to get into reactive airway diseases and disorders. Pretty much, we're going to talk about anaphylaxis in this lecture. Make sure you guys are referring to your respiratory guidelines for treatment. I'm not going to get too much into the treatment on this, just kind of give you a brief overview of what actually is going on when anaphylaxis does occur in our body. Anaphylaxis is very similar to asthma patients, specifically when it first kind of starts happening. And remember that at the paramedic level, we can't just assume that all wheezing and coughing is strictly 100% asthma, as you guys probably learned in basic or intermediate land or whatnot. We're going to start talking more at the paramedic level for you guys in order to understand exactly what's going on in the body when somebody does get exposed to those antigens. Your antibodies start to attack those antigens. Because you're doing that, the mast cells start to pop and the histamine's released, and that's really what causes the allergic reaction. But we'll get into that step by step here in the next couple slides. So when we're talking about the antigen-antibody response, the antigen is the outside source. It's the irritant that's coming in, whether it be a bee sting, cat dander, smoke inhalation. It could be people sensitive to perfumes. It could be people that are sensitive to cold weather. It just kind of depends on what actually is happening. But the true antigens are like the pet danders, the bee stings, or something like that. Okay. So what that does, really, that antibody is just basically a protein that's actually developed by your body in response to that antigen, so that the next time that antigen is introduced into your body, those antibodies will come and attack that antigen and hopefully stop the anaphylactic reaction before it starts. The problem is that the body is very effective at this and actually attacking these antigens, and the body can actually overwhelm itself with the response to the antigen. When we're talking about the actual physiology behind anaphylaxis, we have to have an exposure. An exposure to something that we are allergic to. And remember that you guys can become allergic to anything at any time in your life, right? You guys aren't born with this. It doesn't run in families or anything like that. It just kind of happens to some of us. And it doesn't mean that you're, oh, by the time I get to this age, I'm in the clear. It doesn't work like that, okay? You guys can be enjoying strawberries one day, and then the next day your body doesn't like something in the strawberries and it starts to attack it, and then you guys kind of start this localized kind of allergic reaction. Once we get exposed, once those antigens are into our body and we've been exposed, we start to manufacture IgE, which is the actual antibodies, and the IgE stands for immunoglobulin E. And these are the antibodies that are actually produced by your immune system. So if you do have an allergy, the immune system will actually overreact to the allergen by producing antibodies, the IgEs. And these antibodies travel to the cells. They release chemicals causing the allergic reaction. Those cells happen to be the mast cells. Those mast cells actually start to pop when releasing the histamine. That's what causes your allergic reaction. Okay. The secondary exposure causes the mast cells to release very powerful chemicals, and that's where the histamine kind of occurs. So you guys can look over this slide. I believe this is straight from your book. I'm pretty sure that's where I got it. Maybe not. Don't quote me on that. But make sure you guys look over this. It kind of explains it pretty good. And then if you guys have any questions, I want you guys to refer you guys to the Khan Academy. I love the Khan Academy. I think they do a very good job at explaining what really happens in allergic reaction in a very simplified form. So when the antigen or the antigen-allergen, whichever one you want to say, is actually attached onto the mast cells kind of release their histamines. And it actually plays a very key role in our inflammatory process. We call the mast cells, are also known as feeding cells. And this is actually the body's way, or the body's belief that it is actually nourishing the surrounding tissues with the histamine in order to try to stop this process, right? But again, the body is so efficient at this that the body is actually hurting itself doing this, which it doesn't really realize, which sends us into the anaphylactic reaction. So here are some More common anaphylactic triggers, I guess. Just again, remember that anybody can be allergic to basically anything on the face of the planet at any time. But these are some of the more common ones. Foods like specifically like honey or peanuts, cantaloupes, bananas, stuff like that, right? Medications, self-explanatory. Latex allergies, insect stings as well. Specifically, the big ones being the honeybees. We want to make sure that we are gathering a very good sample on our patients. We want to try to get to this first, especially if we're not seeing the actual signs and symptoms, the true, like point out signs and symptoms such as the hives or the wheals on the body of how the patient presents. But hopefully this is kind of moving up the treatment for you guys when you do have that person that really just has a low oxygen sat, possibly has a normal to elevated end tidal CO2, whether it has a shark fin waveform or a regular box baseline waveform, that we really need to kind of start thinking about, the difference between asthma and anaphylaxis, and depending on how severe the asthma attack might be, we're basically going to treat it the same way in our system, right? So, when you have that patient, specifically younger patients, children, that persistent cough, man, that's usually, something that we really want to kind of start thinking about, that, hey, this could be more serious than it actually looks. So some of the more classic anaphylaxis signs and symptoms, usually we get those hives and swelling. And the hives and swelling is usually right around about 30 minutes after the exposure. It could be before, it could be instantly, right? But it's usually right around or up to that 30 minutes after the exposure. We're going to start really seeing that hives and swelling. And it really just kind of depends on how the body actually responded to this exposure, right? Every person's going to be different, but it's just something that we need to kind of watch out for, right? We're definitely going to get that respiratory distress, that shortness of breath, that persistent cough at first. It could be straight up stridor with severe wheezing, right? Remember, we're talking about that silent chest, right? Anytime that we cannot hear the patient's actual vital sign or the patient's lung sounds from that nipple line down, if we're not getting air movement at all into those lower lobes, that bronchi is so severely irritated and inflamed that we really need to start thinking about going straight to a shot of epinephrine, right? 0.3 milligrams in IM, right, in the delta or the anterior lateral aspect of the thigh. And then if we're using the patient's own EpiPen, make sure that you guys are making sure that it's not expired, making sure it is actually the patient's. And then when you guys go to inject on the anterior lateral thigh, when you push it in, you push the button down, make sure you guys hold it there for about 10 to 15 seconds. That way we can make sure that all that medication gets into their system. Just don't pop it on their thigh and thinking that they got this straight up dose of epinephrine. We have to kind of hold it there in place to make sure that EpiPen does get all the epinephrine into the system. Again, the only difference between compensated and decompensated shock is the blood pressure. Once we start seeing that blood pressure start dropping on our patient, they're going into decompensated shock. We are behind the 8 ball, guys, okay? We really need to start getting aggressive with this patient's treatment. Probably a shot of epinephrine right off the bat. You guys could do a couple of shots of epinephrine. Remember that when you do give that epinephrine, those hives are not just going to magically disappear, okay? They're still going to be there, right? They might stop slowing down the spreading, but they're still going to be there, right? And then we can start thinking about some Benadryl, a Duoneb, right? A little bit of albuterol, a little bit of ipratropium. Make sure that we're monitoring the patient's end tidal, oxygen saturation, mental status, and make sure that we're keeping an eye on the heart rate, okay? After 3 doses of epinephrine at the paramedic level here in the state, you guys do need to call MSEP for further orders. So make sure that you guys are looking at your respiratory guidelines for class on anaphylaxis so that you guys can kind of see how it's worded and how we want you guys to actually run this call if you guys do an encounter with us in a scenario. So some classic just kind of definitions of things that you might find associated with anaphylaxis. The urticaria. This could be a localized reaction or a widespread reaction, a systemic or a localized, right? It is considered the first true sign of anaphylaxis. Obviously, we want you guys to kind of back that up a little bit, right? Yes, somebody can have an exposure to an allergen and develop urticaria right off the bat, okay? Most of the time, at least from my experience, yes, I've seen urticaria on my anaphylactic patients. However, it wasn't really truly the first sign, right? It was either the angioedema or the shortness of breath that comes with it. And then out of all of that, right, with the urticaria, really people can get urticaria from just regular stress. My People can get it from things that are cold. My little guy actually has a localized urticaria reaction when he jumps into a swimming pool and the water's too cold. He actually develops a welt right in his right upper quadrant of his abdominal region. I mean, everything's good. It was just he gets a little cold water urticaria. That's localized. It's really weird. Anyways, angioedema. This is any kind of swelling to the face, the tongue specifically, the larynx, okay, the kind of posterior oropharynx region. This will definitely cause some kind of airway compromise in our patients. And then, again, not all angioedema is an actual allergic reaction. Could be a burn. Could be because of an ACE inhibitor, such as lisinopril for high blood pressure. Medication out there for high blood pressure. That's a famous one for angioedema in our patients. And people, again, can develop a allergic reaction at any point. My dad actually developed angioedema from lisinopril for his high blood pressure. He was on lisinopril for years, like 10, 15 years, something like that. Something crazy, and all of a sudden one day he just developed angioedema. Some NSAIDs and some proton pump inhibitors can also cause it as well. When we're talking about anaphylaxis, it's basically a combination of all of these, of many systems, and with widespread symptoms. So we're going to have systemic head-to-toe symptoms with it. One of the more famous pictures in EMS that you guys will see on urticaria, the hives on this little guy. You can really see it on his left and right butt cheeks. Middle of his back, you can kind of see that blotchiness in his right arm. That's not a farmer's tan, guys. You can see how that upper arm is very pale, and then you have the urticaria coming down the lower aspect of the actual arm itself. But you can see the blotchiness of the skin, specifically around the shoulders and the lower back, and on the butt cheeks as well. So great picture of some hives, classic presentation as well. Another picture of that urticaria. Again, you guys can see on the left. On the left there, specifically around the neck and the face, right? Kind of the blotchiness. With the little wheels, what we call wheels, which are the little circular kind of reddish colored spots. They can also appear to be purplish in color on some people as well. I would be aware of this person just because that is around the airway area on this person. Remember that anything that we see on the skin is also happening underneath the skin as well. The one on the right, it's a little bit more kind of almost looks like a rash, right? But you guys can see that there's really no kind of distinguishing pattern. Most of the time, at least they say, excuse me, guys, sorry. At least they say with a rash, it's kind of unified in appearance, where this one still has kind of the blotchiness going around. But you can see that if you actually look close, I know it's kind of hard to see this on the actual screen, but these are raised. This urticaria is actually raised. I believe this is This is either a shoulder or possibly a thigh on somebody, but these are raised urticarias as well. So we have multiple body systems that are involved with multiple symptoms involved when it comes to anaphylaxis, right? We will definitely have that shortness of breath or that dyspnea. They can have a hoarseness in their voice. They could be more high pitched than usual. It can be actually a little deeper than it usually is. They could have itching, either systemic or even possibly localized. We could see that urticaria, possible angioedema, possible orbital edema, and then again with anaphylaxis, again, the difference between a compensated shock and a decompensated shock, and yes, anaphylaxis is a shock any way you look at it, is the blood pressure of the patient. Once we start seeing hypotension on our patient, or we start seeing signs that our blood pressure is starting to drop, we need to become a little bit more aggressive in our treatment of this patient in order to try to get that blood pressure back to where it's supposed to be. Make sure, again, you guys are looking at your respiratory guidelines for treatment options for anaphylaxis. So with this type of shock, all three of the big three systems, your respiratory, cardiac, and neuro, are affected. We can have some major issues with airway swelling, specifically in the posterior oropharynx area or the tongue. And it can go even further down than that. It can go all the way down to the larynx, right? We can have that wheezing, that extreme wheezing. We can hear that stridor as well. Again, make sure that you guys are listening to your breath sounds and making sure that we are trying to really listen for that silent chest, right? If your patient has stridor, it's going to be very hard for you to hear those lung sounds over the stridor, okay? But do your best and see if you can actually hear the wheezing. But if not, really, when it comes down to it, if your patient's already presenting with stridor and we know that there's not any kind of foreign body airway obstruction down there, we could probably just go straight to epinephrine on this. A little shot of epinephrine goes a long way, and it'll probably do the patient some very well good. Two different forms of shock with anaphylaxis. It's a distributive and a hypovolemic. We are starting to third space that fluid. They are becoming dehydrated due to all the swelling and the irritation that is going on. And then we can cause decreased LOC from hypoxia. We're not getting the perfusion levels that we need to the brain due to the actual losing of the third spacing of the fluid. And then the actual redistributive part where we're dealing with the constriction and dilation of the vessels. I did skip a slide on treatment. Make sure you guys are looking at your respiratory guidelines. Hopefully this is going to force you guys to look over your respiratory guidelines, because I can guarantee that you guys are going to have an anaphylactic scenario coming up soon in lab or possibly during your capstone, okay? So make sure that you guys are looking at your anaphylaxis management and your treatment guidelines so that you guys are on point with that, all right? This is just a little reminder on the actual EpiPen use. We need to make sure that we are removing the cap and the arm, all right, so that we can actually get the actual plunger to activate when we push this against the person's leg, okay? And then we want to press firmly on the leg, and we want to hold it there for 10 seconds so that we will guarantee that we are actually getting all the amount of epinephrine into the patient, and it's not just dripping down the side of their leg. Okay, so when we're talking about angioedema, again, I just want to kind of hit this home for you guys. This is an allergic reaction. It's not a systemic allergic reaction. It is a localized allergic reaction. It happens to be a very important localized allergic reaction because it's dealing with the patient's airway. Okay? We're going to get that swelling to the tongue, the larynx, the pharynx, just anywhere on the posterior oropharynx. We're going to get that irritation and that swelling, which can really hinder the airway of our patients. Okay? Here's the other thing is what's interesting about it is it's not the same as anaphylaxis. It is not because of antibodies that are producing this or the IgE, the immunoglobulin E response pathway. I'm not going to get too much into that, but if you guys want some literature on that, email me, okay? I could probably get you some. If not, just Google it. There's some really good, cool studies out there on why angioedema does happen to some people and why it doesn't. Very common causes are drugs, foods, okay? They are starting to find that this could be hereditary. There's been some research out there for that. A couple different studies posted out there. I think one was done by Michigan State or something. I forget who did. Maybe Ohio State, one of those schools up there. They did a really cool study on one. You guys can look that up. You guys can read up on it. That's a whole other lecture, guys, and I don't want to spend too much time on that, okay? It usually occurs in the night or very early in the morning. So this kind of helps you guys eliminate the possible foods that were eaten the day before when you guys are kind of diving into trying to figure out what might have caused this kind of angioedema reaction in our patients. So again, another famous picture that you guys will see in your paramedic continuing education and studies for the rest of your guys' career. Let's talk about this a little bit, right? This is definitely some angioedema. She has a very severe tongue, as you can see. Hopefully that's pretty obvious. Probably a bottom lip, and I would say even kind of going down into her posterior oropharynx. However, I want you to really look at this patient, okay? She really doesn't look like that much distress. She's sitting there. She's got very good skin color. She's tracking you. She's obviously perfusing. She doesn't look pale. She doesn't look diaphoretic. This lady probably just got lucky and the tongue decided to swell outwards, then backwards, right? So again, this is a presentation of angioedema. Obviously, we still want to make sure that we're getting this lady to the hospital. We still want to make sure that maybe we're trying some Benadryl for this patient, see if that will cause it or if that will help it. More than likely, it won't because it's not an immunoglobulin E response. There's no actual histamine release in this area, but we could try it, to kind of rule it out. But this is definitely something where I would be watching her airway. I would be monitoring end-tidal CO2 and SpO2. And I would just try to keep her as calm as possible. That's really what it kind of comes down to, okay? To be honest with you, compared to the last picture, I'm a little bit more concerned about this little guy here. He's got some blotchiness on his skin, as you guys can see. He looks a little flushed. He might even be febrile. But if you guys look down on his actual shoulder that's shown, you guys can see the wheals. You guys can actually see the urticaria. This is becoming a systemic response, okay? He's got the swollen... lips. He's probably a little swollen around the eyes there a little bit. We have that urticaria going on. More than likely, his tongue is probably swelling. And I would say if we met this little guy in picture or in person, he'd probably be drooling a little bit. So we want to be a little bit more aggressive with this guy than our last one. But either way, I'm not trying to put a category to angioedema. It is a life threat any way you look at it. We need to make sure that we're trying to treat these patients accordingly, making sure that we're doing the best interest of the patient, and most importantly, trying to keep the patient as calm as possible. So classic signs and symptoms: they have itching in the palate, usually right in the hard palate, the top hard palate of the actual mouth itself. They might describe it as feeling a lump in their throats. You can hear the stridor, the persistent cough, and it's usually like a persistent dry hacking cough, almost similar to like a smoker's cough that doesn't produce anything. Shortness of breath, they could have the urticaria as well. So again, when we're talking about angioedema, make sure that you guys are looking at your respiratory guidelines. We're going to treat this very similar to the anaphylactic reaction. We need to do our best to establish an airway, period. Okay? Maybe all we need is an NPA. Maybe all we need to do is try to position our patient. Try some cool humidified oxygen. maybe we need to get more aggressive. Maybe we need to start thinking about nasal intubation or possibly an endotracheal intubation on some of these folks. Okay, but it's all going to be situational dependent. Oxygen for sure is high flow, more than likely through a non-rebreather. We may have to assist if we feel the need in order to try to force that air past the swelling as much as we can. We definitely want to establish big bore 18 gauge or higher IV. We do want to keep a TKO at first, okay, just because we don't want to overload them with fluids. Remember that if this does turn into a true anaphylaxis, they're going to start third space, and we don't want to get those lungs wet for them, okay. Epinephrine 0.3 sub-Q, all right, 1 to 1,000, all right. For angioedema, sub-Q seems to be the better part. You guys can go intramuscular as well, but we really kind of want to make sure that this has this kind of slower effect. I think a little bit more than a straight shot IM. I think sub-Q is probably a little bit better on these folks. And then, of course, you guys can repeat as needed and make sure that you guys are checking out your respiratory guidelines for other information on how to truly establish the airway on this. Some other things that you guys can consider for angioedema at the paramedic level is let's give them some Benadryl. Right, we got that IV established. Let's give them that 25 to 50 milligrams of Benadryl. See if we can help the swelling a little bit on our patients. Again, it might not necessarily work just based on the fact that we're really not dealing with the immunoglobulin E and the actual antibodies themselves. This is kind of a different path that's happening compared to anaphylaxis on why the swelling occurs. But hey, let's try it, right? Let's see what we can do with it, okay? Steroids, you guys got your Solumedrol, okay? Dexamethasone, those are the two that we carry here in our system. I don't think anybody else is carrying anything different. If you guys are, please let me know. But dexamethasone or Solumedrol. Again, possibly has little effects. The effects of this has really not been documented too much, but in that time of need and it's go time, we might as well try it out and see if it's going to help our patient out or not. And again, if it's really severe, we might need a bag. Maybe we can consider some CPAP on this, all right? Endotracheal intubation, nasal intubation, and then if we need to, we're going to go straight to the crike.